Hi, thank you for joining me. I'm Jean Liew from Boston University School of Medicine, and I'm presenting our paper, Cardiovascular Risk Scores in Axial Spondyloarthritis versus the General Population. So first, I want to start with the big picture. Why perform studies focusing on cardiovascular disease and those of rheumatic disease? Because cardiovascular disease is still a leading cause of death and disability worldwide in general. As a reminder, some terminology: cardiovascular disease includes ischemic heart disease and cerebrovascular disease. Major cardiac events include MI and stroke, and then these large boxes at the bottom are established or traditional risk factors for cardiovascular disease, like diabetes, hypertension, and obesity. There's an established cardiovascular burden in AS and axial spondyloarthritis. Studies have shown, compared to the general population, those with AS or axial spondyloarthritis have higher mortality and higher risk of cardiovascular events like MI or stroke compared to those of the same age and sex. And they also have a high prevalence of risk factors such as diabetes and especially hypertension. But traditional cardiovascular risk factors don't tell the whole story. There are other contributors to cardiovascular disease, including systemic inflammation from the disease itself, and medication effects such as from steroids and non-steroidal anti-inflammatory drugs or NSAIDs. So that's part of the background. And the final piece is that in 2013, the American College of Cardiology and the American Heart Association made guidelines recommending statins for the primary prevention of ASCVD, especially for those whose 10-year risk score was 7.5% or higher. So ASCVD means atherosclerotic cardiovascular disease, and it includes some of the items I've shown before. Here's our clinical question, and these are the ASCVD guidelines as a diagram stratified by 10-year ASCVD risk score. So we asked, is there a greater prevalence of individuals who have a high 10-year ASCVD risk score when we compare those of axial spondyloarthritis versus the general US adult population? So the design of our study, we included adults 40 to 75 years old who had available blood pressure and lipid data. Our population of interest were those of axial spondyloarthritis who were part of prospective cohorts from 2 sites in the US, in California and Texas. Our comparator population was from the US NHANES study, pulled over several cycles, and they were age, sex, and race matched 4:1. And we looked at the prevalence ratio for having a high ASCVD risk score comparing axial spondyloarthritis to NHANES. Here's our table 1 for overall everyone in our study, for those of axial spondyloarthritis, and for the NHANES comparators, and these are already matched by age, sex, and race. So those would be similar. And they also had similar percents that were taking antihypertensive medications, as well as lipid-lowering medications like statins. However, for diabetes, this percentage was higher for NHANES, and the same was true for current smokers. And the last row here shows the prevalence of having this high ASCVD risk score, 38% for everyone in the study, and then 34% for axial spondyloarthritis, 40% for the NHANES comparators. Again, these are already age, sex, and race matched. So our prevalence ratios, which again compares the prevalence of having a high ASCVD risk score in those of axial spondyloarthritis to those in the general population, we saw no significant difference in this prevalence. We also conducted a secondary analysis for AS compared to NHANES with similar findings. So the limitations of our study, despite our large numbers, we only had 211 individuals with axial spondyloarthritis, so the study may have been underpowered to detect a true difference if there is one. We were also not able to account for geographic differences in lifestyle and other risk factors, which are potential confounders. And there may be limited generalizability because this is a study of US adults, but the axial spondyloarthritis group was limited to 2 sites in the US and 2 particular study centers. So again, to reiterate our results, The prevalence of a high 10-year risk score was not significantly different between axial spondyloarthritis and the US general population. And this risk score may underestimate the cardiovascular risk in axial spondyloarthritis. What does this mean? We only looked at risk scores and not their actual ASCVD risk. The actual risk might be higher in those of axial spondyloarthritis. And this scoring system is meant for the general population, all comers, and doesn't take into account factors beyond traditional cardiovascular risk factors, such as inflammation or medication use that could all be contributing in people with rheumatic disease. So our take-home message is to not forget screening for cardiovascular risk factors in patients with axial spondyloarthritis, and to ensure good communication with patients as well as with their primary care providers regarding this screening. Thank you.